Good morning, everybody. Today we will be talking about tumors of the nasopharynx. And in the tumors of the nasopharynx, we'll be discussing regarding juvenile nasopharyngeal angiofibroma and nasopharyngeal carcinoma. Juvenile nasopharyngeal angiofibroma, also known as nasopharyngeal fibroma. It is the commonest of all the benign tumors of the nasopharynx, locally invasive but histologically benign and benign vascular tumor. It is seen mostly in young adolescent males. It regresses after adolescence. It is considered as a hamartoma. Pathogenesis exact etiology is not known. There are various theories which include Ringer's theory, Sohm and Nefson's, Hughes, craniopharyngeal duct, Bench and Ewing, Brunner's. So there are various pathogenesis, but you guys just have to know the name of this. The site and origin and growth. Basically, it is present in the posterior part of the nasal cavity, close to the margin of the sphenopalatine foramen. From here, the tumor grows into the nasal cavity, nasopharynx, and into the pterygopalatine fossa. It is basically a dumbbell-shaped tumor. Blood supply of the tumor. It derives its blood supply basically from the maxillary artery and the ascending pharyngeal artery, and from the unnamed branches of the internal carotid. Coming to the pathology of the tumor, angiofibroma, as the name implies, is made up of vascular and fibrous tissues. Mostly the vessels are just endothelium lined spaces with no muscular coat. This accounts for the severe bleeding as the vessels lose the ability to contract. Clinical features: there is profuse and recurrent epistaxis, progressive nasal obstruction, hyponasal voice, conductive hearing loss, and serous otitis media due to obstruction of eustachian tube. This is basically mass in the nasopharynx. With the extent of the tumor, there is a broadening of the nasal bridge, proptosis, swelling of the cheek. And then there is involvement of the second, third, fourth, and the sixth cranial nerves. It will depend on where the tumor extends. Anterior rhinoscopy, there is abundant mucopurulent secretions noted. And when you see the septum from the uninvolved side, there is a bowing of the septum because of the mass which pushes the septum towards the side. In posterior rhinoscopy, pink or red mass filling into the nasopharynx. Peculiarities are: it's a more common in young adolescent males, benign tumor but locally invasive. It has got diffuse attachment and takes blood supply wherever it goes. It has no capsule, no pedicle, and the recurrences are very common. This FISH staging classification is the classification which grades the JNA, and it is basically for the prognosis and the therapeutic approaches. Stage 1, the tumor is limited to the nasal cavity. In the stage 2, the tumor extends into the pterygopalatine fossa, the maxillary, sphenoid, or the ethmoidal sinuses. Stage 3A, the tumor extends into the orbit or the infratemporal fossa without intracranial involvement. In stage 3B includes stage 3A with extradural intracranial involvement. In stage 4A, there is intradural without involvement of the cavernous sinus, pituitary, or the optic chiasm. In stage 4B, there is involvement of the cavernous sinus, pituitary, or the optic chiasm. There is another classification. It's known as Redkowski's classification. In this, stage 1A is limited to the nose and the nasopharyngeal area. Stage 1B, there is extension into one or more sinuses. In stage 2A, there is minimal extension into the pterygopalatine fossa. In stage 2B, there is occupation of the pterygopalatine fossa without extension to the orbit. Stage 2C, this infratemporal fossa extension without cheek or pterygoid plate involvement. Stage 3A, this erosion of the skull base, middle cranial fossa, whereas in stage 3B, erosion of the skull base with intracranial extension, with or without cavernous sinus involvement. Differential diagnosis. You see enlarged adenoids. You made differential diagnosis. How can you confuse this tumor with something else? Basically, if it is an enlarged adenoid, you can confuse it with JNA. If there's an infected AC polyp, if there's an hemangioma, rhinosporidiosis, inverted papilloma, malignancies, and craniopharyngioma, all this can be confused with the GNA. Coming to its investigations, basically we start off with the diagnostic nasal endoscopy. Diagnostic endoscopy is this is the nasal cavity when you do a DNE. You see the septum in the center, you see the lateral wall of the nose in the right, and then there's a tumor which is there in the posterior part of the nasal cavity going into the nasopharynx. And biopsy is absolutely contraindicated. It means you are not supposed to do a biopsy because the tumor is a vascular tumor. It's an angiofibroma. So you touch the tumor, it's gonna bleed excessively, and the patient is gonna crash. So don't do any biopsy. It has to be done in it's a clinical or a radiological investigation or a diagnosis that has to be done. Coming to X-ray, there's something called the Hohmann-Miller antral sign. This is the lateral X-ray. This is the maxilla. This is the teeth and the orbit. You can see that the posterior wall of the maxillary sinus is bowing, and this is known as the Hohmann-Miller antral sign. And the which all conditions you see this sign. Basically, you see it in a GNA, in a schwannoma, in fibrous dysplasia, nasopharyngeal carcinoma, and tumors of the infratemporal fossa. Contrast CT, nose and PNS. If you see in the CT scan, there is similarly there's a mass which pushes the posterior wall of the maxillary sinus anteriorly, and then this is called the brown sign. If you look at the maxillary sinus, you can see the posterior wall is pushed anteriorly compared to this side. So this is known as the brown sign. This is the tumor basically, and this is the sphenopalatine foramen through which it is getting eroded in through this, and it comes into the nasal cavity. There is widening of the gap between the ramus of the mandible and the maxillary body. Okay, this is called the Horndozer sign. MRI. MRI is very specific because it precisely shows the extent of the mass, and it's easier to differentiate it from the other soft tissue. Like if you look at in this picture, this is the tumor. This is how differentiates it from the other soft tissues here. And then if see this is the maxillary sinus with some secretions, so it will tell you what is the secretion, what are the mass. A carotid angiogram is done, so we can see the feeding vessels. So basically this is the carotid which goes and then gives the this is the internal maxillary artery which goes into the sphenopalatine foramen. See, the other vessels can be easily delineated, whereas maxillary artery in the sphenopalatine foramen shows a very hue, like there's a collection hue here, so it shows the tumor here. So basically the main treatment what you do for an angiofibroma is surgery. So that is the most important. We have to excise the tumor. But the thing with the angiofibroma is we have to do a pre-operative planning before we do a surgery, because since it's a vascular tumor, some things have to be taken into mind. And that what are the pre-operative planning? First and foremost, you should do an angiography and embolization. So what happens is you embolize the vessel which is feeding this tumor. So when you embolize it, so the tumor shrinks in size, and it will be easier for you to remove. And this adequate blood should be arranged in case if there's a bleeding and all that happens. So this is the embolization which I'm talking about, which was first done by Robertson in 1972. He did it 48 to 72 hours prior to the surgery, and then it reduces the intraoperative bleeding. The materials which are used are autologous fat and blood clot. Artificial materials can also be used like gel foam, polyvinyl alcohol, and oxidized cellulose. Coming to management, as I said, surgery is the main treatment, other things being radiation and chemotherapy. Surgical approaches, I'm not going into the depth of the various surgeries, but I'll just tell you endoscopic endonasal approach, transnasal palatal approach, anterior approach, that is mid-facial deglobing and lateral rhinotomy, and lateral approach, that is to the infratemporal fossa approach. Endoscopic endonasal approach is the most commonest method which we use, that is we pass the endoscope through the nose, we go to the lateral wall of the maxilla, we remove the lateral wall, along with that we enter the maxilla, we remove the posterior wall of the maxilla. So once you remove the posterior wall of the maxilla, you're entering into the pterygopalatine fossa, where you can see the tumor. So go when you're about to remove the tumor, you have to ligate the internal maxillary artery. Once you ligate the internal maxillary artery, the entire tumor starts to shrink, and then you can selectively remove the tumor and its extent. Other techniques are transpalatal, through which we go through the palate. Then there's midfacial deglowing, that is we pass a Weber Ferguson incision is placed and then midfacial is opened up. And then there's a lateral through the infratemporal fossa, through the lateral side, that is behind the ear you go, and then inferiorly through the infratemporal fossa. Radiotherapy is only considered for extensive tumors which are inoperable, almost 3000 to 3500 centigrade in 15 to 18 fractions or 3 to 3.5 weeks. Another thing is chemotherapy can be given, that is doxorubicin, vincristine, and dacarbazine.